Good morning, everyone. Nice to see you. We were just speaking about how much we wish American conferences started the same way your conference started. That was fantastic. Thank you so much for the invitation. Thank you to Dr. Hoyt as well. There you are. All right, with that, we're going to hop into a topic that has a lot of potential interventional options, hypertrophic cardiomyopathy. Hopefully to provide you a backbone about how to think about and approach the disease without necessarily going into the specifics of different structural interventions that might be done on the disease process. So at the end of today, I'd like for you to be able to think about certain clinical challenges that might arise with a hypertrophic cardiomyopathy patient through the lifetime of their disease process. Any of these problems could occur along the way with hypertrophic cardiomyopathy, but I'm going to try and give you moments in a patient's life where they frequently are encountered. We're going to talk about new data around exercise. We're going to talk about the American guidelines for surveillance screening with hypertrophic cardiomyopathy. And then hopefully I'm going to introduce to you the concept that hypertrophic cardiomyopathy is a very heterogeneous disease. That's probably multiple diseases rather than a single disease process. We're going to do that with a case-based outline here. And we're going to start with this gentleman. This was a 23-year-old gentleman who came to see me in clinic because he had some chest burning and because his primary had heard a murmur. This was a gentleman who had played collegiate ice hockey, which is a very aerobic sport, and had described chest burning for years that he thought was just from cold, from the ice, from hockey. He did have a maternal uncle that had heart disease. Here was his EKG. If my fellows were in the audience, they would be jumping out of their seats at this EKG to say, I'm worried that that's hypertrophic cardiomyopathy. The deep T-wave inversions through V6 are a telltale sign. And if you were to screen this individual for sports participation, this would have screened as abnormal in any age. Here is a parasternal long axis view of his heart. So at the top chamber there, you're going to see the right ventricle, the left ventricle, the left atrium. Hopefully what you can appreciate, even if you don't read these frequently, is that the septum dividing the right and left ventricle is significantly more thickened than the wall that's more posterior. If you read a lot of these, you might notice that there's some brightening of the septum right there. That's probably from recurrent contact of the anterior mitral leaflet against that surface, which is abnormal. And if you showed me this in isolation, I would tell you this patient has obstruction. And just to make sure we're on the same page, when I say obstruction, what I mean is that there's a pressure difference inside the left ventricle and the aorta. So normally, the pressure inside the heart and in the aorta are the same. If you have an obstructive process, the pressure inside the heart is going to be higher. And he was given a diagnosis by me in clinic of obstructive hypertrophic cardiomyopathy. He underwent testing, which showed the MYH7 variant. This is the second most common mutation, the first one that was described. And his only question to me in clinic, the only thing he wanted to know was, I have a tryout for professional hockey, can I still do it? Didn't want to know about his disease process, his family, his chest burning. Can I continue to play sports? And this is pretty common in this age group. So to make sure we're all on the same page, let's define hypertrophic cardiomyopathy. I've alluded to the definition a few times, but let's make sure we all understand. This is a process where you have a heart muscle that's thicker than 1.5 centimeters in absence of another cause. Now that second part is a little bit gray, it's a little bit undefined. How much high blood pressure do you have to have before a thickening of the heart muscle to 1.5 centimeters makes sense? For how long do you have to have it? Well, that's somewhat at the discretion of the physician. A normal heart muscle, just to put this in context, should be less than 1 centimeter or 1.1 centimeters in females and males. Now, if you went back to the 1990s and you read editorials about hypertrophic cardiomyopathy, what you would see is a promise that this is going to be the great genetic cardiovascular condition. We're going to be able to define everyone's genetics who has hypertrophic cardiomyopathy. And all these patients that looked slightly different are going to be put under one umbrella. This was done by Cricket Seidman's lab at Harvard in 1992. Fast forward 30 years, and what you'll find is, if you take everyone who has a diagnosis of hypertrophic cardiomyopathy, it turns out only about a third of them are going to have an identifiable genetic mutation. Now, I'm not saying that the others are not genetic, but what I'm saying is we can only identify the cause in about a third of these patients. The remainders are negative or have uncertain findings. I want you to pigeonhole that away. I want you to remember that, because when I introduce this concept later that this is possibly two diseases, I want you to flash back to this slide. Now let's go to our gentleman's question. Can I exercise? Well, if we had asked this question in the early 1990s, what we would have seen is a definitive no. The Bethesda Conference was the defining governing body for whether or not athletes could participate. And after several American athletes died on national television, international television, in very high-profile fashions, and were found to have hypertrophic cardiomyopathy, people said, this isn't safe. They can't exercise. Now, there was no data to support that beyond these anecdotes, these single incidents, but that's what the ruling was. In the meanwhile, America, like the rest of the world, continued to get more and more obese. And patients who had obesity and hypertrophic cardiomyopathy did even worse than other patients. I'm going to fast forward through a number of trials and just tell you that when the 2020 guidelines came out, there has been a complete, almost 180-degree change around this topic. We have several trials that support the notion that moderate intensity exercise in these individuals is safe. By moderate intensity, I mean if you answered the phone, you could speak a sentence. You're a little breathless, but you could still speak a sentence. And this is the guidelines that show you, for most people, class 1 recommendation, moderate recreational exercise is encouraged. What the guidelines did not do was they did not say, go be a professional athlete. They said, look, we don't really know if vigorous athletics is safe. When we look at autopsy data, it seems like HCM is enriched. There's more HCM in patients who have sudden death. But we're not sure that we're actually capturing the right comparator, meaning maybe there's just more HCM in the general population and we don't know because we don't look. If that didn't make a lot of sense to you, what I would say is, at the end of the day, these set of guidelines said, we don't know what to do with vigorous exercise. Could be safe, could not. We're not sure. Last year was a pretty exciting year in HCM because the LIVE HCM trial came out. Now, this was a trial that had around 2,000 patients with HCM, and it was a pretty sick group. Around 1 in 4 of these patients had a defibrillator for either primary or secondary prophylaxis from dying suddenly. So, risky individuals. But what I think you can appreciate is whether or not you did vigorous intensity exercise, which was the randomization here, seemed to make no difference in outcomes. Another way to think about this is maybe individuals that are at high risk of dying suddenly, they might die suddenly whether they're doing sports or not doing sports. Sometimes when they die suddenly, it's during sports. But I'm not sure, based on this trial, that vigorous athletics itself pushed them into dying. They might just be high-risk individuals. Now, there is a guideline update pending within the next few months in America that's going to address this, and I suspect that the guidelines are going to loosen even further and say maybe we need more shared decision-making with our young patients about professional athletics, but we're starting to get data that suggests maybe we don't know as much as we think we did about what the risk of these individuals is. Back to our patient. So I shared all of this, and it was my first visits with HCM patients are around an hour. I'm very lucky. I get a full hour with a new HCM patient. They usually bring their families. I shared all of this, and I was quite convinced at the end of the appointment he was going to try out to play professional hockey. He came back 6 months later and he said, "I'm not trying out." And out of curiosity, I said, "Why?" Well, he'd gotten married, engaged, and he had just gotten into law school. Bless him. So, point being, I think with our patients, what we need to do is be very honest about what we know and don't know, and we will be very surprised sometimes how strongly they might make a decision one way or the other, just like this individual did. All right, with that, let's segue into a second case. This was a woman who was coming to me with a possible diagnosis of hypertrophic cardiomyopathy. She had a very loud, provocable murmur in clinic. So when she had a hard time valsalvaing, but when she squatted, the murmur disappeared. She stood, it got very loud. Here was her echocardiogram. This is a little bit less thick than our other gentleman, but hopefully, again, you can appreciate the septum separating the right and left heart is thicker than that wall over there. And hopefully you can again appreciate that that part is bright, probably a scar from recurrent contact from this mitral valve and the obstruction. Here was her resting echo. The way that we measure gradients on echocardiography is by assessing the velocity of flow between two chambers. If there's a high pressure gradient, the fluid moves quickly. Low pressure gradient, it moves slowly. This is a pretty unimpressive pressure gradient. We consider 30 at rest to be significant. This was 10. So we had her Valsalva bear down to try and decrease blood return to the heart, to try and make the gradient worse. And when we did that, it got worse, but not a lot worse. 36 millimeters of mercury. 50 is considered significant. However, I was quite sure she had worse obstruction than that, just based on her symptoms, my exam, and that finding of septal brightening right there. So her question to me was, why am I coming to see you again? Well, you've diagnosed me with HCM. Can I go back to my other doctor that's 4 hours closer and just see her? And so what we focused on in this visit was what routine surveillance looks like in HCM and what things I think I'm providing when I follow these patients over a period of time. So this is the American guidelines, and it's going to go through what we do from year to year in these patients. Every year they get a history, an exam, an EKG, an echo, and they should be getting some sort of atrial fibrillation screening. Every 3 to 5 years, they should get a CMR, cardiac MRI. And every 2 to 3 years, they should get a stress test, even if they don't have symptoms. Now notice that's a 2B recommendation, which means it's a less strong recommendation, but it's still in our guidelines. I want to highlight 3 areas of surveillance that I think are underutilized by cardiologists who see a lower volume of these patients, because I think that these are 3 important parts of the routine surveillance that are easily missed. So we're going to focus on the monitor, the cardiac MRI, and the stress echo in the asymptomatic patient. So if you'll recall, her resting gradient was 10, but I didn't believe it. So we exercised her. And when we exercised her, the pressure difference between her left ventricle and her body was 250 millimeters of mercury, meaning if her exercise blood pressure was 150, the pressure in her heart was 400. Now, for those of you who read echo in the audience, you might be saying, I don't believe that, Michael. Are you sure that's not just the gradient between the left ventricle and the left atrium? Here's her MR gradient that shows the pressure difference between the left ventricle and the left atrium is 384 millimeters of mercury. This is a real deal gradient of 250 millimeters of mercury in a woman who's endorsing minimal symptoms. This is just to tell you, I frequently will add a VO2 or a cardiopulmonary exercise component to this. And the reason I do that is there's a nice study out of the Cleveland Clinic that took all of their HCM patients who said, I don't have symptoms, and then did a VO2 component to measure cardiac output. And what they found was, of all these patients who said, I'm fine, I have 0 symptoms, Only 1 in 5 could do an average exercise capacity. You're going to hear from pediatricians later, and they're going to tell you the same thing. If a patient has severe pathology on echo, they have symptoms. Their world might have gotten smaller. They might not know they have symptoms, but they have symptoms. Briefly, and this will be of interest, I think, for our stroke colleagues later, it turns out about 40% of HCM patients develop atrial fibrillation, and their risk of stroke is somewhere around 4-fold higher than you would have predicted with normal calculators. So the guidelines recognize that fact, and they say, whether you have symptoms or not, you should be screening these patients for atrial fibrillation every year. Longer screening can even be considered in a patient with no risk factors and no symptoms. You might be thinking to yourself, my patients hate wearing those monitors. Do I really have to convince them to wear that monitor every year? Well, here's a nice study that took patients who were getting a defibrillator, and it showed of these 86% of the patients getting defibrillators at implantation who were in normal rhythm, 1 in 4 developed AFib that they didn't have symptoms from. 1 in 4 have an elevated stroke risk, 4-fold higher than what you thought, and they don't tell you anything about palpitations. AFib screening is very important in this group. Very high stroke risk, don't use Chad's VASC, just start a direct oral anticoagulant. With that, I'll go quickly into cardiac MRI. MRI is a very, very powerful tool in HCM. It's very useful if your echo's inconclusive, but it's becoming increasingly important to figure out who's at risk of abnormal rhythms from the bottom of the heart, ventricular tachycardia, ventricular fibrillation, and sudden death. If you look at this chart, I think it's very compelling. What it says is the more late gadolinium enhancement, SCAR, the more SCAR you have, the more likely you are to die suddenly. Turns out you could probably reproduce this slide with a number of cardiovascular conditions. SCAR is bad. Here's just a nice picture of somebody with some punctate scar at the apex or tip of the heart. The American guidelines have really embraced cardiac MRI, and if you'll notice, so if you've died suddenly before and been brought back to life, you need a defibrillator. That's primary prevention. Focusing on the that's secondary prevention. If you've died suddenly and been brought back to life, secondary prevention. Primary prevention, a lot of these indications that will buy you a primary prevention defibrillator. Massive thickness, reduced function, aneurysm, extensive scarring on cardiac MRI. A lot of those features are found with more sensitivity and specificity on MRI. Again, highlighting, to make the diagnosis and risk stratify your patient, you need a cardiac MRI. It's also good at showing you different morphological abnormalities associated with HCM and really making sure you're measuring the thickness correctly. All right. This is just a nice study that we recently published from our center where we looked at 6 months of referrals. So these are cardiologists sending me a patient that they think has HCM. Out of those 210 referrals over a 6-month period, 1 in 6 didn't have HCM. Almost all of those changes in diagnoses were made with cardiac MRI. A lot of these patients have amyloid, ATTR, transthyretin amyloidosis. That's a totally different treatment paradigm, a totally different screening. Those patients need to be managed completely differently, and a cardiologist had thought they had HCM until we saw the CMR, the MRI. Okay, so for that woman we said, look, there's lots of things I think we're doing for you. We're screening you for AFib. We're going to exercise you and make sure we understand that you're really asymptomatic. We're going to get cardiac MRIs. We're going to do a lot of things for you. All right, this last gentleman, going to be slightly older than our other 2 patients, 67. He's coming in with shortness of breath, another loud, provocable murmur. His cardiac MRI shows 1.8 centimeter septum, so he has HCM. You can tell that this individual is a little bit older because there's some calcification on the mitral annulus. Again, parasternal long, right ventricle, left atrium. And again, I think probably the easiest example of a very bright basal septum, recurrent obstruction in this individual. This is somebody whose mitral valve has been hitting that septum over and over for years. Here's his stress echo, which shows both the MR and LVOT gradients. 75 millimeters of mercury. This is a patient with symptomatic obstruction. Now, this gentleman had a number of questions for me. He said, am I going to die soon? Do I need to write my will now? What does this mean for my family? What can we do for my shortness of breath? So this is a pretty exciting time to be in HCM because the number of treatments have really exploded. As many of you know, the treatments in the past have been high doses of beta blockers and calcium channel blockers to try and reduce the obstruction, or surgery, or alcohol ablation, invasive procedures. This is the European guidelines, and I'm going to give you my version of the European guidelines. What the new medicine in town has done is really allowed us more medical options to treat these patients. So the new medicine is a cardiac myosin inhibitor called mavacamten. It normalizes the density of actin and myosin interactions. So at any moment in time, actin and myosin, about 50% are interacting for your individual squeeze, your individual beat. That can be upregulated when you exercise, downregulated when you're at rest. In HCM, that number's closer to 70-80, which is what creates the hyperdynamic squeeze. There's an abnormal density of actin and myosin interactions. Well, what mavacamten does is it normalizes that interaction, decreasing how hyperdynamic the squeeze is and improving obstruction. It has pretty dramatic results. So what we now do with these patients is we say, look, we will start our obstructive patients on a beta blocker, on a calcium channel blocker. But our threshold to move past that has been greatly lowered. And I will go ahead and tell you my approach at this moment in time is to offer them at the same time mavacamten, clinical trials, surgeries like a myectomy where they open the chest and cut out the thickened part of heart, or an alcohol septal ablation where they inject the blood vessel that feeds the thickened section of heart and opens up the outflow tract. And I offer all of those things simultaneously. So the first thing I told this gentleman is not only do you have options, you have a lot of options. You have 3, 4, 5 options about what we can do for you. Same thing, shared decision making. I let the patient decide what he or she is most interested in. With that said, you might have noticed that there's been different shapes of hearts as we've been going along, and you might remember that I was talking to you about the genetics of this disease, how about 30%, 40% have an identifiable mutation and the rest don't. Well, it turns out that the shape of the septum, dividing the right and left heart, is very predictive of what your genetics is going to be. So our last gentleman had just this isolated basal segment right up here. And so when he asked me what this means for my family, I told him, it's pretty unlikely you're going to have an identifiable mutation. Compare and contrast that with our hockey player who presented at age 20-something. I told him, I'm going to be surprised if you don't have an identifiable mutation. Just of note, the apical variant is the most common variant in Southeast Asian cohorts, tends to have a more favorable prognosis, tends to have less obstruction. And so you see a lot of this in Southeast Asia, as I'm sure you're all aware. With all that said about the different shapes of the septum, dividing the left and the right heart, it might be time for us to approach this problem differently. Maybe our monogenic single gene mutation folks, the hockey player, are one disease, and that disease presents younger, has more abnormal heart rhythms, more sudden death, less obstruction. And maybe our last gentleman, who is in his 60s, is a different disease, is a polygenic, multiple gene, predisposition to heart thickening. Presents older, has more obstruction, less sudden death. And the reason I'm bringing this up is we're applying the same guidelines and the same treatment algorithms and the same family screenings to both patients, but I think we all instinctively know those are different patients. And should we be approaching them differently? I think this is the question that the next iteration, after the one that's coming up, of guidelines is going to address. How to think about these two groups differently, which are even different still from the apical variant that I mentioned earlier. So he asked me, do I need to get my life in order? Am I about to die with this diagnosis? Well, it turns out once you hit 60 with HCM, you are much more likely to die of run-of-the-mill heart disease, no offense to any general cardiologists in the room, run-of-the-mill cancer than you are thickened heart muscle. This particular graph is just showing you that the younger group are going to have many more HCM complications than the older group in terms of time of diagnosis. Again, highlighting to you, maybe this is two different diseases. The reverse curvature parentheses septum and the isolated single segment septum. So with that in mind, you want to treat all the other stuff. So what I told my gentleman that came to see me last was, we have to focus on all the other things that we manage in cardiology clinic: blood pressure, cholesterol, sleep, exercise. And I just wanted to take a moment to really point that out with a single slide, because for those of you who have taken care of individuals with more rare disorders, it's sometimes very difficult to remember to do these things because you get so focused in the single disease process. My last note, and this is really just an aside, in America, with all the resources and spending per patient, etc., it turns out we do a lousy job of taking care of these patients' families. 1.6% of the time, we're genetically testing our HCM patients. 1 out of 50. I do also want to mention the screening of people who have the isolated basal septum, my last gentleman who came in. The family screening yield is much lower in that group than in my hockey player who came in with a very thick septum at a young age. I will also mention to you, I've said cardiac myosin inhibitors and mavacamten a few times from now. This is a very exciting drug. We think that it's getting at the true pathobiology, the true cause of HCM, whereas beta blockers were just kind of bludgeoning you to make your heart squeeze less hard. We think mavacamten is targeting what causes the disease. And in that vein, in that same thought process, what we see is mavacamten in the trials caused walls to get less thick, atria to get smaller. Is that evidence of disease modification? Is it changing the trajectory of the illness? I don't know, but it's certainly suggestive. It's also a very exciting time. UVA will be a participant in these trials. There are 2 gene trials coming out, 3 gene trials coming out in America that are looking at gene editing and gene replacement therapy in these groups. So in the MYH7, they're going in with CRISPR-Cas9 technology and literally snipping out the bad and replacing it. And with the MYBPC3, they're stuffing the whole gene in an adenovector and delivering a normal gene to patients. So it's a pretty exciting time in HCM and in all genetic diseases. So in summary, our exercise data is inconclusive. It looks like moderate intensity exercise is safe. Vigorous might be. We just need to be honest with our patients about what we know and what we don't know and see what they want to do. Guidelines are requiring a ton of surveillance in these patients. Don't forget MRIs. Don't forget AFib screening. Don't forget to exercise your patients. Make them prove to you that they don't have symptoms. Sudden death rates in general decline after 60, so take care of everything else. The treatment approach for obstruction is a changing landscape, and there's more and more options. And then I suggested to you that these might be multiple diseases. The genotype positive patient, who's got the thick septum presenting at a young age, and the genotype negative patient who's presenting later in life with much lower rates of sudden death. With that, I will hand off to the next person. Might have run over, there's no clock, that's dangerous for me. and we will keep moving. I'm very excited. Do you want to stop for questions or just have Dr. Wendell come up? So let's have Dr. Sarah Wendell come up. She is one of our medical directors. We're very excited to have her. She's considered a national expert in quality, and enjoy her talk.